Trudi, you're now live.
Good afternoon. I'm Trudi Seneviratne, Registrar of the Royal College of Psychiatrists. I'm absolutely delighted to welcome you all to one of our 180th anniversary free webinars for our members. Today's topic is the impact of war on psychiatry in the UK, planning after a prolonged crisis. We have a huge number of you hopefully listening in, about 330 delegates at last count to have registered. So I'd really like the delegates to ask as many questions as we go along. We have two absolutely fantastic speakers for you. If you could please use the Q&A function as we go along. The presentations will be shared with you after the talk, and I'm sure our speakers will give you permission for that. And there'll also be certificates emailed to you after the event today. If you are wanting to tweet, please do tweet at RCPsych, hashtag RCPsychLive. So moving on to our two speakers, we have Professor Edgar Jones, who is going to speak to mental health service reform post-World War II, and Dr. Geraldine Strathdee, who is going to speak to how should long-term mental health policy be planned post-pandemic. So if I could kindly invite Professor Edgar Jones, who is going to speak to mental health services reform post-World War II. So Edgar is Professor of History of Medicine and Psychiatry at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. He originally trained as a social and economic historian at Nuffield College, Oxford, before completing a doctorate in clinical psychopathology at Guy's Hospital and training as a psychodynamic psychotherapist. He is a program leader for the MSc in War and Psychiatry at King's College London and works in the field of military psychiatry, exploring how both soldiers and civilians cope with the stress of war and enduring its effects on their mental state. He is co-author of Shell Shock to PTSD, Military Psychiatry from 1900 to the Gulf. His research into the Second World War includes papers on the epidemic of gastrointestinal illnesses suffered by members of the armed forces and the treatment of psychiatric battle casualties. His 2020 UK mental health outcomes was published in Lancet Psychiatry, explored how myths about wartime mental health allowed politicians to delay reforms and almost led to psychiatry being excluded from the National Health Service when it was established in 1948. So please can I invite Edgar to talk. Thank you very much for being here. We look forward to your talk.
Thank you, Trudi. Thank you for that kind introduction. So, mental health service reform post-World War II. There were really three major events which happened during the war, which frame the reforms that were tried to be introduced in the 1950s and into the 1960s. The government sponsored two major pieces of research, and the first identified that civilians who had been subject to intense repeated air raids suffered from enduring severe traumatic illnesses. And this obviously affected a significant section of the industrial urban population. It was also recognized in the Second World War that veterans who'd been held in prisoner of war camps or had extended periods of overseas service would potentially encounter difficulty reintegrating into civilian society and returning to productive employment. And the government also commissioned in 1943 a survey of community and outpatient services and recognized that there wasn't sufficient to cope with the increased demand that the war could potentially create by bombing and overseas fighting. So it's these events that really frame thoughts about how you would design a health service in the post-war period. So looking first of all at civilians, as you can see, there were nearly 150,000 civilians in the UK killed or seriously injured, and the majority were in London. But the really significant studies were done in Hull. And Hull was subjected to intense attack because it was a port and it was on the eastern coast. And 0.4% of its pre-war population were killed in a series of heavy raids in 1941. But more than that, it destroyed almost half of the port's housing stock. So if people survived, they were very likely to have lost their home and their job. And the government picked Hull for this reason for a detailed study. And Russell Fraser, a New Zealand psychiatrist, with a team of researchers, did a major study of people from these heavily bombed areas. He found in a follow-up study, 10 months after the raids, that nearly a third were continuing to suffer from distressing symptoms. And the other worrying thing, it wasn't that these were people with a history of mental illness. It wasn't that they had relatives or parents who'd suffered from mental illness. The crucial thing was, it was the bombing itself. So these were people who'd previously been well adapted and performing, a productive job. So this is a warning sign to the government that you can't assume that people who've been traumatized will get better automatically. With this evidence in mind, the government then had a much more detailed study of 7 towns, choosing different types to try to understand what the causal factors were. And from the evidence principally of Clydebank, which again, an industrial area of Western Glasgow, which was hit very, very heavily, very high killed and wounded rates, lots of housing destroyed, and schools closed for a significant period. They found that the things that really determined who was going to suffer badly and experience enduring mental illness were those who'd had close friends and relatives killed, lost their house, lost their employment. So the government by 1943 had a pretty good understanding of who was likely to break down. So it's going to be people, significant numbers of people in the urban and industrial population. With this knowledge in mind, the government is beginning to plan how they're going to set up mental health services once the war's over. And in 1943, they go to Carlos Blacker to conduct a major survey of outpatient clinics. Now, they picked Blacker because he was an infantry veteran. He'd been a decorated soldier in the First World War, so he knew at first hand the impact of trauma. And he trained after the war in medicine and in psychiatry at the Maudsley. And this is what he discovered. That nearly 60% of the 159 directors of psychiatric clinics in England and Wales believed that there was an underlying latent neurosis, what we would, I guess we would say, sort of incipient PTSD or post-traumatic illness in the civilian population, which is likely to emerge in the post-war period. And this was related to where you lived. So if you were in the countryside or in a remote area, then the chances are that the war hadn't had a great impact on your mental health. But if you're in a center of industrial production or of a port, so crucial areas for post-war recovery, if you want the economy to get going again, there's a good chance that a good section of your workforce is not going to be performing well because they are suffering from enduring psychological symptoms. The curious thing is that the psychiatrists in London actually were much more sort of sanguine about this. And we think that's probably because London had been promoted as a symbol of resilience. And they kind of bought into the popular belief that Londoners could take it. London's tough, no one's going to bother us. As a result of his report, Blacker urged significant investment to address shortages of staff, nurses, psychologists, psychiatrists, but also a major building program and a lot of money invested in community services so that people with post-traumatic illnesses could be treated in the community in outpatients. So it's at this time also that the government's working on their white paper for the National Health Service. And one of the crucial elements of the new National Health Service was to integrate psychiatric care and physical medical care. But very early on, their plans to integrate the two systems met concerted opposition from the Board of Control. The Board of Control had been set up in 1913 from the Commissioners in Lunacy, and it regulated the national asylum system. And it was really not happy about losing its powers because they would have to be transferred to the Minister of Health. And they set up a vigorous campaign of opposition saying that this would require changes to the law and in turn would require a royal commission, so it could not be done quickly or easily. So progress towards an integrated NHS stalled, and the Chief Medical Officer's report in 1936 made no mention of psychiatry, and it almost looked as if the government was going to drop psychiatry in order to progress the NHS in other areas. In the event, the Ministry of Health backed down and agreed to the Board of Control continuing to exercise authority over the mental hospitals. And then it kind of agrees because its executive power has been protected. And it's only in 1959 with a new Mental Health Act that the Board of Control was finally abolished, and that move towards a really proper integration of the two services could go ahead. So this was fundamentally delayed for over 10 years because of the opposition of the Board of Control. And I think the key figure was probably the Honourable Walter Macleay, who had been the medical superintendent at the Maudsley Hospital in Mill Hill. And I know from reading the papers there that he had enormous battles with Aubrey Lewis, who was the professor of psychiatry and who was a reformer and wanted change. So there's something about the Board of Control that is conservative and protecting its powers. So although when the bill goes to Parliament, psychiatry is in there, the problem is all the reinvestment and reforms recommended by Blacker get pushed aside. And one of the reasons why all his ideas are rejected and psychiatry continues to be marginalized is because of the myth of the Blitz. So in 1940, when Britain is facing invasion, the myth of the Blitz is created by the Ministry of Information. So a film is made, talks are given, showing just how tough and resourceful Londoners are, despite the bombs falling, despite the death, despite the destruction of buildings, they're tough. Nothing can touch them. And Joseph Goebbels, the German Minister of Propaganda, recognizes how successfully this is done after Hamburg is horribly bombed, in I think it's 1942. But the problem is that this myth works really well in 1940 when people are worried about invasion. Once that threat is gone, it actually has a counterproductive function because it prevents people from coming forward, from admitting that they're suffering from mental illness, because it's seen as a form of defeatism, a form of weakness. So in the immediate post-war period, Churchill in particular, politicians characterized Britain as a new nation. Brexit is supposed to have fashioned us into a new nation, but they said the war had fashioned Britain into this adaptable, resolute nation, which doesn't need mental health services. We don't need to spend this money because everyone's coped fine. And in fact, the official history promotes the idea that Britain's mental health has improved in the war. It's actually got better because we had this sense of common purpose, this shared identity. We're no longer wedded to empire. We're now a new modern society where everyone is working together for industrial and social progress. So the myth of the Blitz undermines the claims of psychiatry for funding within the new NHS. But the reality is that that's not true. We can see from war pension data that large numbers of civilians are being given war pensions for post-traumatic illness, and half of them at least are in payment in 1956. So those are enduring treatment-resistant disorders. And just, in Germany, which was bombed much more heavily than the UK, 91% of the population said that bombing was the most traumatic experience of the war. So you can imagine a similar effect in the UK. And in addition, we've got at least 50,000 UK veterans awarded a pension for a psychological disorder, and there's no specialist treatment available for them apart from short-term admission to mental hospitals. The government had recognized in 1944 that returning prisoners of war had significant mental health issues, and their behavior had altered as a result. And so there was a short period in the summer of 45 when they set up civil resettlement units to give servicemen an opportunity to re-socialize, to learn some basic employment skills, and to try to address some of the underlying traumatic illness. But because of staff shortages, no psychiatrists were deployed to the units. They were supposed to be there, but they just simply weren't the numbers. So the NHS comes into being in July 1948, and you can see it has an enormous challenge in terms of existing patients continuing to be in the system, and actually having lost a large number of mental health beds to the emergency medical service. So they're lost to medical wards and surgical wards treating people who've been wounded or sick as a result of air raid. So it's already starting behind the curve. And we can see here that during the 1950s, the number of patients in asylum beds falls only marginally. And roughly half the people in asylum beds, half the patients, are long-term chronic patients. So that there's not a lot of movement there. There is sign of progress, because we can see that 40% of new admissions in the 1950s are discharged within 3 months and 80% within a year. And there is a significant increase in the number of outpatient attendances throughout the decade. And the government, what money it's got, it invests in mental health nurses, increased by 30%, and consultant psychiatrists up by 33%, at a time when the population is only grown by 5%. But I suspect the shorter treatment times that you're seeing and the expansion of outpatient services is probably made possible by the therapeutic revolution of the 1950s, because there isn't a lot of extra money coming. As we'll see, the government is actually cutting expenditure on the NHS, and psychiatry is right at the end of the queue. So probably what allows these changes to happen is the new drugs that come in progressively in the 1950s: antipsychotic, antidepressant drugs, mood stabilizers. So that's a sort of bit of serendipity which enables the reforms to take place that the government, in a sense, has not really prioritized. And this is really my last couple of slides. I guess the big thing at the end of the day, you can only do what you've got money for. And the big miscalculation made about the NHS was how much it would cost. They got the cost wrong by a factor of about 100. They underestimated it by half. So the real cost is actually double what they thought it would be. And of course, once it gets going, the cost goes up dramatically. So, but it's actually, compared to today, only 3.75% of GDP. But Clem Attlee, the Labour Prime Minister, was alarmed by first of all, the amount it was and the fact that it was increasing. And he himself sets up a committee to reduce the expenditure as fast as possible. And it divides the Labour Party, and the Labour Party lose the 1951 election. The Conservatives continue, I suppose, more effectively at cutting, and have managed to get the cost of the NHS down to 3.2% of GDP by 1954. But compare it to what we spend these days, 1997, 6.9. Today, it's around 10.2%. So you can see psychiatry had hardly any opportunity really to introduce the reforms that were understood, where they had the evidence for, to introduce these new community services, to build new hospitals, to open community psychiatric clinics, because the money just simply wasn't there. And it's not really until the new Labour mental health initiative, as late as 1998, that you can see a significant increase in real terms in psychiatric spending, and in relation to other areas of the NHS. In the 1950s and 60s, it's the other parts of the NHS that take all the extra spending rather than psychiatry. So my conclusion then is that the World War II gave us the evidence, and it taught about social psychiatry, the importance of social psychiatry, about groups, because it's communities that are exposed to bombing. The military organize themselves into communities, and they sort of understand that people support each other in times of adversity and can provide valuable social support once the trauma is over. Sadly, the power of the Board of Control and the vast capital investment, this huge asylum system, and the amount of money and buildings that it involved served as a brake on reform. I mean, it was the idea that this new NHS could take on this great organization of mental health services in the 1950s was kind of unrealistic. So my argument is that it's really the 1960s, when the Board of Control is finally swept away, the new 1959 Mental Health Act, that you can then get to work with just psychiatric services and district general hospitals, the community, start to begin to close the asylums and really change practice to meet the understanding that came in the Second World War. Thank you.
Edgar, thank you very much. That was really interesting to listen to. I've got lots of questions already. So I think the best is to move immediately to Geraldine. Can I encourage everyone to please post questions in the Q&A so that when we come to the end of Geraldine's presentation, we can have your questions at the end. Thank you. And now moving on to Dr. Geraldine Strathdee, who is going to speak to how should long-term mental health policy be planned post-pandemic. So Dr. Geraldine Strathdee, who has a CBE and an OBE, as well as being an honorary FRC Psych, has held numerous senior roles in mental health policy, regulation, and clinical management. Both national, London and regional levels, and has advised internationally on mental health service design and quality improvement. She has been involved in numerous transformational large-scale service development programs, moving services from hospital-based to 24/7, 365 home care and primary care models. She's been involved in the development of the PHE Fingertips Population Mental Health Informatics, sponsorship of digital services innovations, including the Mental Health Global Digital Innovations, and a range of safety and quality improvement programs. Current work programs include modern, sustainable, integrated estates, use of technology to enable home care, safety transformations in urgent and emergency care. Her particular commitment is to the translation of policy and best practice evidence into frontline routine clinical practice, empowering service users to reach their potential and staff to maximize their time to care. She's also extremely passionate about the development of leadership competencies and using information to enable informed decision-making. So Geraldine, we're absolutely delighted to have you. So I shall ask you to take the stage. Thank you.
Great. Thank you so much indeed, Trudi, for that kind of very generous introduction. And thank you, Edgar, for a wonderful, stimulating presentation. I'm really very deeply honored to be invited to speak at this 180th anniversary of our profession. I'm always been interested in history. I felt very honored to be asked to speak after Edgar, and he and I had wonderful conversations about what the learning could be. My interest in history has been there for a long time for a number of reasons. One is I wonder about the human condition and human behaviors. How can we affect change in that? What are the lessons we can learn, wonderful lessons that Edgar has articulated about the precursors of war situations? What happens during that war? And then very importantly, what need to be the kind of reflections and learning after that war situation in order to achieve a better world for future generations. And also the impact that that has on any health and integrated care system. One of my personal reflections really has come from growing up in a culture of conflict. I'm Northern Irish. I was 10 years old when the Troubles blew. And even as a small child, it was very obvious in that precursor of war and conflict that things were going to happen. There were divided communities, excluded communities, poverty, a sense of not having parity of opportunities, and different cultures. And it's taken a long time and many decades to try and achieve change and improvements. I also have found it very interesting over my years working in policy and regulatory and other systems to try and understand, well, what constitutes good leadership during a war situation, but really also after the war situation? Is a great leader to lead battles? Is that the same characteristics as a great leader who could help communities rebuild inclusiveness, sustainability, developing the infrastructure that gels people together? So in my talk, I just wanted to do a few things. I wanted to reflect on my thoughts as a ex-national clinical director and someone who's had the utter privilege to be involved in several different eras of mental health policy in the UK. I wanted to reflect on what are the kind of the planning lessons from these iterations to date. So I will reflect during the rest of my talk on the lessons from Edgar's talk. What's the same situation post-war now in terms of the inclusiveness in mental health in the healthcare system and in our society? I'm going to think a bit about the battle that many of us have been fighting for our entire lives. It's a battle, if not a war, to get mental health onto the agenda, achieving the same level of support in our society, in our communities, in our big institutions of all types, including the healthcare system. Where are we at in winning that battle to get mental health right up there on the agenda, sustaining it, and then with the resources needed to achieve good policy making? I'm also reflecting on the standing on the shoulders of giants. Policies are off their time and off the context. We've had some fascinatingly interesting policy making in mental health in England, moving from the deinstitutionalization, the closure of the large water tower and other institutions, the first stage of trying to develop community services, which it has to be said was very, very fragile, and then rapidly followed by the transformational national service framework in England, which moved us to some extent, Blacker's dreams, away from outpatient clinics and towards 24/7, 365 intensive community teams, early intervention, crisis home treatment, assertive outreach, some of which have stood the test of time. And my own experience of policy was just the enormous privilege of being part of the process, the bottom-up process, where service users and families and staff and members of our society created the 5-year forward view policy from NHS England. And that policy really was the very first national NHS policy, which had the one document about developing mental health plans. And in it were physical service plans, but also mental health service plans. Chief Exec Simon Stevens was passionately committed to mental health, and actually have mental health embedded in a key national policy. I think that people that Edgar mentioned would have been kind of very, very pleased and very proud that they'd led some of the foundations for that work. The COVID pandemic. I think we have so many lessons and reflections to learn from the COVID pandemic. I don't know about you, but everybody that I know has had a different COVID. has had a different pandemic experience, depending on their personal circumstances. For some of you, it will have been the Hull experience, and for others, it may have been the London type experience. For many, it's been a really, really hard but successful story. For others, it's living with the pain of isolation and loss, not being able to see your families, tragic bereavements. And I think for so many in this era, with the pain of having conditions that have not yet been diagnosed and that the NHS is desperately running to try to catch up and treat. But I also think that in the long-term planning, in the lessons for long-term planning, one of the important lessons we have to think about in terms of the planning is, what have been the big failures in our policies around mental health over the generations, over the decades? And to me, the biggest has been that pandemic that is sitting there in plain sight. The pandemic of the causes, the untackled, unidentified, unaddressed causes of the development of mental ill health. Child abuse, physical, sexual, emotional, children living in poverty. I would love to meet Marcus Rashford and shake his hand, that young footballer. How fantastic to have young members, leaders in our society who actually speak out against poverty, speak from personal experience. But how come we have not tackled that pandemic? I don't think I've ever spoken to an audience of psychiatrists, and when I've said, can everybody just write down on a post-it, what's the one major prevention initiative you would like to see in policy and planning, that 80% of the audience has not said, we would like to see physical, sexual, emotional abuse, children, women, and vulnerable people tackled properly in our society. I think the other, and I'm not calling it a failure, but I certainly think I personally believe we're at a real stage of having to give pause, is about learning from the successful, fast implementation in policies in other sectors. I'm not sure we're doing that so much. I think when we reflect on COVID and some of the supply chain issues, when we reflect on governance issues, was, what was on our risk registers? And did we have risk registers and governance processes that were about acting to prevent a pandemic, acting, role modeling, simulating what the response might be? It's been a really, really hard situation for everybody to deal with well, but I think it's really important that we do learn the lessons and we reflect on them. And as I say, we may have very different views, but how great that we can share them digitally. So I think for me, lesson number one, in terms of if you're thinking of planning future policies, is what's the context of our society? Policies are very much about context. So I had the huge privilege some years back to be invited to a meeting of all the international healthcare leaders from a whole number of countries. And some countries said, well, we're studying what you're doing in England, and we find it fascinating that you're trying to tackle informatics and digital. You're tackling each stage of the life course. You're talking about women's mental health issues like perinatal and eating disorders. You're putting liaison teams into acute trusts and focusing on that. But actually, we're trying to do more downstream. We're starting with communities and looking at, well, what could promote well-being in our communities? Can we teach our population to have some of that resilience that London was said to have, that Edgar talked about? And then one other health person leader said, well, actually, we're aiming for happiness in our population. And I have to say, as an audience, we looked and went, ooh, that's a real kind of mind breaker. And that particular leader said, yeah, but we've got lots of oil money, so we actually think we could achieve it. So where do we think we now are in England society post-COVID? We know that war situations are often when people can be at their most resilient and best. But we also know that it's the aftermath, when the realities of loss, poverty, unemployment, difficulties in adjustment, actually that's when you often get more of the problems and the challenges around mental health. Will the fact that we've had a digitally connected world have been helpful, have been a protected factor? Are the policies that we had tremendous support for people? Will those have been helpful for people? How can we possibly think and reflect on the trends that are now happening that will lead to a mental health pandemic? I think the second major lesson I'd like people to think about, which has stood me in good stead over time, is what's the purpose of a policy? And for me, the purpose is about the vision of how it will improve people's lives in the fastest time possible, and how it will reduce duplications, will cut out things that take staff away from caring for people. Policy is only as good as its implementation plan. So the method, any policy that comes up, the method of how it's generated and how it's implemented will be critical. And I think that's where it's vital that we move to a position where we really study hard how other industries, the fire services that moved in a 15-year period from intervention, responding to accidents, incidents, fires, to prevention. You may have noticed that the vast majority of fire services work is about preventing fires, educating the public, supporting them, nurturing, modeling what needs to be done. The airline industry and the transport industries that had a safety track record that was of great concern, perhaps just as short ago as a decade, but who have looked at the pathways, have listened to the customers, have mapped the pathways for customers, have mapped the pathways to implementation of safety policies into routine practice, have stood back, have tested out the feasibility of the implementation of a policy and iterated and iterated and iterated it until they got it right and it was possible. The nuclear safety industry. I wonder if some of the systems we have at the moment in the NHS, maybe 200 policies per large organization. Ask any junior member of staff of any profession, have you read the 200 policies? Have you been able to assimilate, because many of them are about 200 pages long, have you been able to assimilate what this policy is asking you to do to improve lives? And is it easy to implement? And then think, actually, is this the way to achieve improvement through policy? And I think we have great lessons from other industries. I think one of the industries we have a lot of lessons from are veterans, where veterans services are well established. I'm a vice patron, great privilege, of something called the Poppy Factory. And at the Poppy Factory, we come together to support using evidence-based techniques, but adapted to the situation to help people get back into paid, valued, high quality improvements. It's something we also try to do in the NHS. We have very high rates of getting people into employment in the third sector, in the Poppy Factory sector, much higher than we have in some of our statutory sector services. What can we learn about engagement techniques, about the messages that we convey to people? I think my entire life long has been spent talking to anybody about leadership or change or improvement is about the comm strategy, the communication strategy. The dean of my medical school was a very wise man, and he used to say, if you can't make it simple, it means you don't understand it. And if you don't understand it, you can't help people understand it and act on it, and therefore it's not going to happen. So where are we at in our communication strategy about mental health in England? My personal kind of top favorite list to go forward would be, one is tackling the pandemic of abuse, which is at the absolute heart and soul of so much of the causes of mental ill health, is about continuing to engage the population of England, from the House of Lords to Parliament to big boards of organizations, but above all to the people living in our country, to engage those people in the DNA of mental health, but not just about, very importantly, mental health treatment, but also about understanding how can they build their own resilience. How can we do more to understand child development, to understand how to help a child sleep at night, to understand how to help young parents do parenting, the hardest job on earth probably, to understand how can schools help people with a kind of a life skills in building your own safety plans, your own resilience plans, your own mental health, healthy plan, as well as physical health. These are some of the initiatives that I personally would really like to see. I think the other huge lesson we've had from COVID, which has been brilliant, is about the power of science when it puts its mind to tackling an immediate problem that is there for a lot of people. The incentives are very clear. It's about improving the science and improving its implementation immediately to help more people have benefit faster. Can we apply the same science? Can we talk with our scientists in mental health and see, can we kind of do that same sort of orientation? And I just want to finish, because I really am very, very keen to hear your questions, with the words of Dame Claire Marks. So Claire Marks was a very unusual woman who became the president of the Royal College of Surgeons, and then the chair of the General Medical Council. And of course, clinical practice is at the heart of this. And Claire says, I wanted to write to you all to let you know that I am stepping down from the GMC, having recently been diagnosed with pancreatic cancer. Since receiving this news, I've been reminded once again of the importance and the power of kindness in all that we do as doctors. Receiving my diagnosis reinforced to me that kindness from the medical team, neat outcomes are not always the norm, but kind words can soften the blow of bad news, and empathy and understanding undoubtedly ease the burden. There is no greater comfort than human connection. So I leave us with that message about policies: human kindness, compassion, helping other people understand their lives, helping other people bear their scars from the battles of war and endeavour. Thank you.
Geraldine, thank you so much, and for again an absolutely wonderful talk, and for ending with those words from Dame Claire Marks. I think really poignant. So let me move on to, there are some questions I can see being posted. So please, thank you to the audience for posting these, and please do keep posting as I ask some of these questions. So perhaps Edgar, this one perhaps to start off for you, would you be able to say a little more about how to help patients with PTSD from other wars and military experiences? And the person who posted said, I have just seen a male in clinic with PTSD, and I had a great feeling he poses a chronic high risk to complete suicide sometime in the future because he does not wish to talk about his experiences, but is clearly affected by them.
I think what's increasingly coming out is that a high proportion of veterans suffer from complex PTSD or treatment-resistant PTSD, because the traumas that they've experienced are either very severe or extended over a long period of time. And it's also sadly the case that a lot of young men and young women who go into the most dangerous jobs probably come from some of the most vulnerable families as well, because armed forces present themselves as a new family. And so if you've had an abusive upbringing, poor education, you're very often attracted to the armed forces, partly because you haven't got the qualifications to get jobs elsewhere. But the military do set out to appeal to that group and can, in some cases act as a protective, restorative employer, because they're all embracing. So the problem now is to find ways that address complex PTSD and moral injury. And I think we're we're at the stage where people are doing research, because the standard PTSD treatments for, say, me, having an assault this evening, they don't work in about 60 to 70% of veterans. So at the moment, I think it's seeing what works, and I think it is that empathy that Geraldine was talking about, and understanding military culture and understanding often where the veterans come from, not just their military experience, but the family or the lack of family before they joined.
That's lovely. Thank you, Edgar. Perhaps just another one to follow, which follows nicely from that last question. Do you feel that the war had an overall positive or negative influence on the standards of inpatient mental health care in the UK?
The Second World War.
Yes.
Yeah, I think it set the standards. You had places like the York Clinic at Guy's, where opened in April 1944. They managed to find somebody who would invest in inpatient treatment, so that they set up a treatment unit on a human scale, wards of about 12 beds rather than 50, patients having individual rooms, higher staffing ratios, exactly the same as what happened with the Maudsley. The Maudsley is conceived before the First World War, but it's set up on a more human scale with higher staffing ratios, with a more holistic approach. And I think that's what wars, both the First and Second World War, did, that they offered an alternative form of treatment to the asylum, because the asylums are there as a sort of statutory way of treating the severely mentally ill of the county. And so the standard of care is very variable, depending on the wealth of the county and the number of patients that they're receiving. So you do, very quickly, the other thing that wars do is they bring in doctors from other specialisms. So you get a development of multidisciplinary treatments in wars.
Thank you, Edgar. There's a question here: have we recovered from COVID? Are we post-COVID yet? I suspect we're not, given the numbers of people that are still positive everywhere. So I think we're still in COVID, aren't we? So we're still discovering what this is all about. Geraldine, perhaps one for you. I think the question is, do you think just worded slightly differently, but do you think the creation of the dispersed mental health services, have they been adopted by non-psychiatric services in the UK, or not adopted by them?
So I suppose where we're at, I think, in England at the moment is, I think we've made enormous progress in getting the population to think about mental health. I mean, we wouldn't have been having these conversations 5-10 years ago. I mean, I always quote the figure that, say, when I first became National Clinical Director in 2012 in England, we had only 15,000 people ever access the main NHS website on information. And it was all about it was called the Schizos Clinic and the use of the Mental Health Act. And there was that automatic link on the main website with violence, and only 15,000 people. And by 2016, and thanks to the power of some way of social media and digital and good communication techniques, we had 32 million people from police services, fire services, educationalists, universities, as well as the health system, be interested in mental health. And I don't think that interest will ever die. But I think, as I said, I think two things are now happening. One is, yet again, and it happens every 3 years, and in your lifetime, Trudi, you've probably got several more years of this, but every 3 years there's a reorganization of some major sort. And so we're reorganizing into 7 regions, from 12 to 7, and 42 integrated care systems. And so we can't sit back on our laurels and think, well, mental health's up there, there's really great national long-term plan policy, and expect that it's definitely going to be implemented. So I think that there is always a risk when you change the structure, whether it's more dispersed or more kind of centralized, that we will have to yet again sit and do some public education of people. My question to everybody in the audience, whichever country they come from, and certainly for people in the UK, in England, is, have you looked at the policy, the main plan for your local integrated care system? Have you clicked on the link? Press Control Find and see how much there is in there on mental health, because they should be numbers. And what I have spent the whole week on boards of different organizations with people saying, yeah, but it'll all be about the numbers. It'll all, and I mean, do you mean the money numbers? And they, yeah, of course, always about the money. And I'm very proud that we can now say in mental health, the numbers, we now have numbers about need. Look at our public health information, our fingertips tools. Look at our Zero Suicide Alliance sites about, what are the key risk factors? Look at the amazing digital analytic developments and artificial intelligence and the collaboration for population action. That there can be nobody who can say, but we didn't know what the level of mental health need would be, and we didn't know what the effective treatments were, and we didn't know how to implement, because that knowledge is in the public domain. But it's fantastic. We've got such a great leadership team, yourself, Trudi, very much included, and Subo and others at the college who can actually articulate those sort of things. So I would say to people, don't worry so much about the dispersion of things. Look and see what's going on in your own patch and feed that into the college and feed it into others, and let's see how we can help.
Thank you, Geraldine. I'm just going to jump to a question I had for you, actually, which is, you talked about the skills of a leadership and leaders. Psychiatrists listening in, what are the skills of psychiatrists as leaders? What would you like to see psychiatrists doing as we attempt to recover from COVID, moving through COVID and recover? What skills do people need, do you think?
I'm just in awe of how hard people have worked in this pandemic. So I think the current skills that people need are, one is that skill about, that I think we all need, of understanding how to support. What is our own safety plan? What is our own mental health plan? Not just our patients, but our plan and our family's plan. Do we know who our trusted network of support is? Have we built that up for ourselves? Because I think psychiatry is a tough profession at the best of times. And I think resilience is really, really important. So I think that's understanding yourself. I've always said that the next most important skill for any leader is being able to communicate. Negotiation skills, partnership skills, collaboration building skills. Those are vital attributes, certainly for the world that we're going forward. If people don't, my mantra, Trudi, if people do not know the numbers, you are just another anecdotal opinion. So we have so much information in mental health, but I think I would urge people to read Robert Wachter, who came and was asked by Simon Stevens to do a review of England's informatics and digital policies. Read Robert Wachter's views. I think they're absolutely excellent. And that is about, we must have more clinical informatics. We must have people that understand the information, that can discuss it. It's very exciting what's happening in digital informatics at the moment. And I just hope that people can do that. But above all, I think that the clinical practice, Claire Mark's words about, in your heart and soul, show what your vision of care is, know where it's good. Don't be proud about learning from elsewhere. I mean, if I look at the variations in England of, say, the use of Section 136, so please see people who look very distressed and make an assessment, and then they're placed on a Section 136 of the Mental Health Act. And the variation in the use of that is from 3.5 per 100,000 in one area to 475 per 100,000 in another, and anywhere in between. And there's no relationship to any demographic factors that you can kind of come up with. It is really to do with practices. So I'm excited by the fact that we now have such more sophisticated information. We can actually identify where people are doing something interesting. We don't need to wait for a 17-year trial. We can do it and iterate and talk about if we get it wrong. Does that help? So know yourself, communication skills, know what good looks like, be proud to try things out, and always with your heart and soul on this is the difference it's going to make to the lives of my patients and my team, my wonderful teams.
Thank you, Geraldine. Edgar, I've got something for you, which is, I'll just read it out. So, with a significant population of our patients living in the UK having experienced current wars and conflict in the Middle East, Asia, Africa, and beyond, I guess, do you think our services have appropriately adjusted to support these groups? I've found there to be a gap for these group of patients in my area.
Yeah, I think that's one of the problems generally of treating veterans, and it applies in America as well, where they have larger armed forces. It really depends where you are in the country. So there may be some parts of because the UK armed forces don't recruit equally across the UK. They go to particular areas, and often areas of socioeconomic deprivation. So it's very likely that if a soldier goes back to where the area they grew up in, they will find that the uneven mental health services will impact on them. So it is one of the issues that, because our armed forces are relatively small and getting smaller, it's very difficult to provide high quality service across the nation. And so that, I think, is a significant problem, given the fact that veterans often need particular understanding of military culture and, as I said, often suffer from complex PTSD. So it is an issue. And the gaps tend to be filled by the charities, but the charities over the last 10 years, or the last 2 or 3 years, military charities have declined in huge numbers because they've gone off the radar. And even the major charities like Combat Stress are not getting the income they had before, and they've had to cut back their services dramatically. So it is a significant problem coming out of the pandemic.
Thanks, Edgar. And just on to a slightly different point, but perhaps if you could answer the next one. Should the college focus on public and media understanding of severe mental illness? It's so difficult to convey the experience of it if we compare with Jasper's, etc., from writings there, compared with the common mental disorders. What could we do more in that space?
I don't know, Geraldine, you may have a more clearer view on that than I.
So maybe every single policy iteration that we've had, and I've mentioned just a few of the highlight ones, there's a movement of the pendulum. So it can swing towards more downstream understanding, more treatment of people with, I would say, immediate traumas, and away from people with psychoses, with complex difficulties. I am very concerned because working with people with psychoses and all the complex physical, social, addiction and other comorbidities has kind of been, for me, the biggest passion lifelong. I am concerned. I'm concerned about when I look at our national clinical audits, and that's why I'm urging our scientists to think again and to really think about what can we learn from the COVID scientist experience. If I look at our national clinical audits, are we really making progress at the speed that we think we should? I don't think people are going to invest in our services if we can't demonstrate that they're effective. They're effective, the science has proven they're effective, and we can implement them. I'm personally not convinced that the pace of change is good enough. I think there's lots of ideas of how we could. I can't believe that we're still seeing such low levels of people prescribed medication, which we know will cause comorbidities, physical comorbidities, obesity, cardiovascular disease, respiratory disease. And we aren't 100% of the time doing the physical checks, the safety monitoring, encouraging people to rate their own side effects, that we aren't supporting people with how to take medication, that we aren't using Robin Murray's evidence base about many people will not need to take it lifelong. I really would urge, and that's why I'm saying when we reflect, let's look at the battles that we've not been winning. I'm not sure we've been winning enough of the battles about how to effectively, safely improve and keep focusing on people with SMI. We've not been able to, I think, persuade enough people to tell their stories about how they've recovered, how they're back in work, how they're back in employment, how the employment is valued employment. And maybe that's because many service users who recovered just want to put it behind them, or they're still really worried about the stigma in the workplace if they talk. But I don't think myself that we've nailed it. How can we still be putting people into inpatient units that, you know, if you look at the Care Quality Commission's reviews of services, it's inpatient units they really worry about. How can we not be following the evidence-based people like Robin Murray on medicines management? How can we still be doing prone restraint on people, many of whom have had prone restraint as their primary form of trauma that has often triggered psychoses? That's the one that I think I have lots of ideas, but if I ever had my time to do again, that's something I'd want to concentrate on.
Thank you, Geraldine. I think we're possibly just coming to the end of our time, but perhaps, Edgar, can I just pose one more quick one, maybe a really quick response for the last one. How do we provide our staff, perhaps generalize it to all mental health staff, because I can see that we've got some international listeners as well. How do we provide our mental health staff the opportunity to recover from mental health trauma of this pandemic in a situation where we have a huge backlog of patients and increasing pressure to work harder once the COVID situation has resolved? Final response from you for that one.
That's a really difficult question. I'm trying to think what they did in the Second World War. I mean, the thing I take from the Second World War is the importance of community, of people sharing experiences and setting up informal self-help groups where they gather together, shared experiences, because they had mutual understanding. And because there wasn't the trauma services that we have today, most people were able to cope. And I think it was through having lots and lots of informal social networks, of having lots of bridging social capital as well as bonding social capital. I mean, that's not going to solve severe exhaustion or burnout, but it'll help people on the margin, I think, because the evidence is that it worked in the Second World War or after the Second World War. Bonding and bridging capital, lots of social networks of different types.
Thank you so much, Edgar. And I am so sorry, but we have not, so apologies to the questions I haven't been able to pick up from our two speakers, but can I just finish and thank Professor Edgar Jones and Dr. Geraldine Strathdee for two incredible talks this afternoon, and thank you for taking our questions. If you have time, it'd be great if you could respond to some of the questions we've not been able to answer. That would be really good. So thank you so much. We'll stop there. Lots to think about, lots to reflect, and lots to take forward. Thank you to everyone that's listening as well and have joined the webinar.
Thank you, Trudi, for your leadership of this brilliant facilitation.
Thank you indeed. Yes, thank you.
It's an absolute pleasure.
We must get together and talk blacker, Edgar.
Ah, yes.
What an influence on my life, would you believe?